Okay, today we're going to discuss heart failure. And I think it is important that we have an understanding of heart failure since it does affect 5 million people in the United States. When we are finished with this lesson, I am expecting you to know a little bit more about the pathophysiology behind heart failure, be able to compare and contrast left side heart failure with right side heart failure, identify the priority problems for your patient, explain nursing management of the heart failure patient, and explain how common drug therapy will improve the cardiac output and prevent the heart failure from becoming worse. Before we are able to discuss anything about cardiac, we should talk a little bit about the forward flow of blood, how the blood actually circulates through the heart and the pulmonary system, so that you are able to understand when I talk about backflow, okay? So here's a great little picture of the heart. I would like for you guys to know that the heart is made up of 4 chambers. The 2 chambers at the top are your right and left atrium, and they hold blood and passively give blood to the right and left ventricles. Okay, so we're going to talk a little bit about them so that you will be able to know what is going on with your patient. So first, I'd like you to know that blood is coming in through the inferior vena cava and the superior vena cava. And this is your deoxygenated blood. It's already given blood to everything. Coming back home, it ends in your right atrium here. It then goes down through this door, and this door is what we call the tricuspid valve. It ends up in your right atrium here. Then comes up through the pulmonic valve, goes up through the pulmonic arteries and out to the lungs. Here in the lungs, it receives oxygen. So the gas exchange happens out here in the lungs, and obviously it's going on over on this side as well. And then we're going to come back in through the pulmonary veins. And yes, I do mean pulmonary veins. Oxygenated blood is coming through veins at this one time. Ends in the left atrium, comes through the mitral valve, and ends into the left ventricle. Little FYI about the left ventricle, it is the biggest and strongest. You see the nice myocardium here because it has to pump through the aortic valve, which is this door here, up into the aortic arch and out to systemic circulation. So I wanted to cover a little bit of that so that you would have an understanding of where the blood is coming from, where it's going to, so that when we start talking about its inability to pump effectively, you will know
ejection fraction,
exactly what's going on. Ejection fraction. When you think about ejection fraction, I want you to think about all the blood that is in the ventricle during diastolic. Ventricular filling is going on. Then there is contraction. The amount of blood that is pumped out, the percentage of blood that is pumped out, is called the ejection fraction. So surprisingly enough, everything that is in that ventricle doesn't come out, but the amount of blood that does come out is the ejection fraction. And the normal ejection fraction is around 55 to 70%. Okay, so let's keep that in mind. So when we're talking about ejection fraction, you'll have a pretty good idea of what I am talking about.
Okay.
And as you can see,
so
from
now
the
since
picture
we've covered
there, it's showing you
anatomy and physiology
what's going
of
on
the
with
heart,
that blood.
let's get down to
and everything
some other
that's going on
terminology
with
that we
heart
have to
failure
discuss.
is actually happen. That is not a healthy heart that you are looking at. Preload and afterload. So these are my favorite 2 terms to talk about. You can't talk about the heart without knowing what preload and afterload is. So when you think about preload, I want you to think about the volume in the ventricles right before they're about to contract again. So diastole is the filling, the relaxing of the ventricles. Relax, 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 and fill with blood, and fill with blood. Right before it's contracting again, that's preload. That amount that is at the end right before it contracts again. So when you think about preload, I would like for you to think about volume. Okay? Afterload is the resistance that the ventricles must overcome to eject blood into systemic circulation. Let's try it one more time, because students normally struggle with preload and afterload. Preload is the amount of resistance or the amount of pressure the left ventricle has to overcome in order to pump out into the system. Yes. So when you think about afterload, I would like for you to think about big tubes or big vessels or little vessels. Okay? So you can think of vasoconstriction, vasodilation, whatever you want to think about. I want you to think about the vessels on the other side that the heart must work against. So if those vessels are dilated and open, the heart doesn't have to work so hard. Got, an open highway. I can just pump regularly. But if those vessels are small, the heart has to work that much harder to get through those small little vessels. Okay? So I want you to think about volume when we think of preload, and I want you to think about resistance, and we actually call that systemic vascular resistance. Okay? Or, some people might call it hypertension or whatever. But it is the amount of pressure the left ventricle has to work against. Now, another term I want to throw out there, and I didn't even think about this, but another term that I would like to throw out there is going to be cardiac output. And you always want to think that people know what cardiac output is, but not everybody knows. First of all, I would like to say that cardiac output is stroke volume times heart rate. So as long as you can remember that, then we can talk a little bit more about cardiac output, because I'll mention that a lot while we're talking about that. So the normal stroke volume is somewhere between 50 and 60 cc's or milliliters, whatever you want to call it. Okay? And stroke volume is going to be the amount of blood that is pumped out every time the heart beats. That is stroke volume. So I'm going to pretty much put it out there like when I'm teaching in front of my class, and with every stroke, you want to know how much volume is coming out. That's stroke volume. Whereas cardiac output is the whole output. So in a whole minute, it's the output, okay? Not the with each stroke or with each beat. It's the whole output. So in order to get your cardiac output, you're going to have to know how much each stroke is and how many times the heart is actually beating. So with that being said, if your stroke volume is 60 cc's an hour and your heart is beating at 80 beats a minute, your stroke volume is going to be 4,800. We do it in liters. Cardiac output normally is somewhere between 4 and 8 liters of blood. Okay, so that would be 4.8. So does that kind of make sense? So we're going to talk about preload. We're going to talk a lot about afterload, and we're probably going to mention cardiac output a million times. So I wanted to make sure that you understood. Cardiac output is stroke volume times the heart rate. Stroke volume is the amount of blood that comes out with each beat. Its normal range is 50 to 60 cc's an hour. Cardiac output is the amount of blood that is pumped out of the heart in a minute, and it is normally between 4 to 8 liters of blood. Now let's talk about the meat and potatoes. This is why you're here. This is why you decided to listen to this video. Cool. Heart failure is the abnormal condition involving impaired cardiac pumping, impaired cardiac filling. The heart is unable to produce enough cardiac output to meet its metabolic demands. one of the things I want to say to you is that heart failure is not a disease. It actually is a syndrome. It is a clinical syndrome. And we'll start talking about the way it is clinically manifested so that you will understand that. I picked heart failure to place up here is because when you compare heart failure with other cardiovascular disease, the incidence of heart failure are increasing every year, and the prevalence as well. And I think this is due because we have gotten more fancy and we've gotten better with saving lives, basically, or the survival of having cardiac events, and we do have an increase in aging population. Let's talk about a little statistics because I want you to know just how important this is, because a lot of this comes with nursing education, us educating our patients, us knowing how to take care of our patients, and knowing what interventions to place in and when to tell them to call us. Heart failure is associated with a very high morbidity and mortality rate. The hospital mortality rate is about 4%, with the average day in hospital being about 6.5 days. It is the most common reason for hospitalization for patients that are 65 years of age. Our patients end up having a reduced in exercise tolerance, a diminished in quality of life, of course, and a shortened life expectancy. So this is some serious stuff, and that's why I want to take enough time to sit and talk to you about it, okay? So cardiac output is always going to be diminished. It doesn't matter what kind of pump failure we talk about, because heart failure is an umbrella term. Because we have left-sided heart failure, we have right-sided heart failure. So I want you to know that it doesn't matter which one of these heart failures we talk about, and I'll go on to explain the different types, they all end up having a diminish in cardiac output because the pump has failed. So let's talk about it. Who's at risk? So primary risk factors are going to be coronary artery disease and advancing age. But then there are some risk factors that are also contributing to this. And of course, it's going to be hypertension. And when we think about hypertension, the first thing that comes to my mind is that increase in afterload, right? Diabetes, tobacco use, obesity, and increase in cholesterol. We're going to talk a little bit more in depth about how these things attribute to heart failure. So we'll think about that. Hypertension is the major contributing factor, increasing the risk of heart failure threefold. Keep that in mind. So now we're going to start talking about systolic dysfunction and diastolic dysfunction. So when you hear me talk about systolic dysfunction, we're talking about ventricles that cannot pump effectively. That's pretty much the classic symptom of what heart failure is. Ventricles that cannot pump effectively. Now, check this out. Diastolic dysfunction is ventricles that cannot relax and fill during diastole. The ventricles cannot relax and fill during diastole. So that's kind of goofy because everybody likes to relax, but we're going to talk a little bit more about it. Systolic failure, systolic dysfunction, classic symptom is going to be a decrease in left ventricular ejection fraction, okay? So we talked about the ejection fraction. It is a percentage of that volume that comes out when the left ventricle is contracted. So systolic dysfunction describes an abnormality in a heart muscle, a decrease in contractility, okay? Usually caused by an impaired contraction, okay? And so what's going to cause your heart to have impaired contraction? Yes, necrotic myocardium. So this is going to be your patient who has previously had an MI, okay? An increase in afterload. Yes, that's going to be your patient who have had uncontrolled prolonged hypertension. Cardiomyopathy. The classic definition of cardiomyopathy is a diseased heart muscle. And then mechanical abnormalities, and that's pretty much your valves, any kind of valvular disease. And usually that's going to be more like your aortic stenosis. Okay, so now we're going to talk a little bit more and we're going to move on to diastolic failure. Okay, so diastolic failure is characterized by high filling pressures. And of course, those high filling pressures are high because the ventricle is stiff, it's it's not compliant, it's not stretching properly. And so this results in venous engorgement, okay, in both the pulmonary system and in the systemic system. So basically, in real words, I'll go ahead and put it out there. The ventricle is stiff and it can't fill properly. And the reason why it can't fill properly is because it doesn't have that stretch. It doesn't have that elasticity to stretch and feel and relax. So it's kind of tight. And it won't relax so you can do this. And it is usually based off, the diagnosis is based off of pulmonary congestion, pulmonary hypertension, ventricular hypertrophy. But here's the key. Remember I said systolic dysfunction or systolic failure, you're going to have a decrease in the ejection fraction. With diastolic failure, you normally have a normal ejection fraction. I know it's kind of weird. It is kind of weird, but that's pretty much what's going on here. With the diastolic failure, your patient doesn't necessarily have the classic cardiovascular issues that are going on with it. But it's usually, like I said, caused by ventricular hypertrophy, chronic hypertension, or hypertrophic cardiomyopathy. And that's basically your stiff, non-compliant ventricle. Okay, now let me get everybody on the same page. We have this blanket or this umbrella term called heart failure. And what ends up happening is we're talking about the heart's inability to pump or fill effectively to meet the metabolic demands. That's the umbrella. Up under that umbrella, the heart is having problems with either contracting or filling. Either way, you're going to have a decrease in cardiac output, a decrease in the amount of blood that comes out every minute. Now we're going to talk about, is the left side tripping or is the right side tripping? So left-sided heart failure, we used to call it congestive heart failure. We're trying to move away from calling it congestive heart failure because not all left heart failure is associated with fluid accumulation. Now, granted, I will tell you, we still call it CHF in the hospital, but we are trying to move away from that. Like I said, we're trying to stay a little bit more focused on that umbrella term of heart failure. And then it is two types of heart failure. We did talk about that. With congestive heart failure, when you think about the congestion, the blood backs up into the lungs. So usually you're going to have the pulmonary congestion and edema. And that's pretty much where congestion actually came from. So all your symptoms are going to be pulmonary symptoms, okay? It wouldn't be a lecture from me without one of my little cute pictures. So here's your guy here, and he is having symptoms from left-sided heart failure. And he's having a paroxysmal nocturnal dyspnea. Remember, that's the dyspnea that wakes you up in the middle of the night because you're having a hard time breathing. He's having elevated pulmonary capillary wedge pressures. And I will actually do a video about hemodynamics, but I'll give you the short term. Wedge pressures are measuring left side of the heart. Pulmonary congestion. So this guy is coughing. This guy has crackles at the bases. He's wheezing all over the place. He's coughing up blood-tinged sputum, and he's tachypnic, okay? And of course, he's having all these issues because the left ventricle is not pumping effectively. It's not emptying out. So with that being said, it's backing up into the pulmonary system, which is where it came from. And with all of that congestion going on over there and all of that craziness going on in the lungs, this guy is getting a little hypoxic. So he's restless. He's confused. He can't lay flat to sleep or anything. So he has orthopnea. He's tachycardic. He can't walk without having a hard time breathing. So he has dyspnea on exertion. He's tired And guess what? Look, his lips are blue. He's cyanotic. So along with that, we'll have some oliguria, some breathnesses, and he'll also have some weakness with that. So, and we will talk about a little bit about why he's going to have a decrease in urine. So, of course, we have to talk about right side heart failure. So, the right side heart failure is the back of blood into the right atrium and then into venous systemic circulation. So, same thing. Left-sided heart failure, we're backing up into the pulmonary system, where right-sided heart failure, blood came from the system back up into the system, right? Remember, the right side of the heart receives the deoxygenated blood from the system. Some of the causes for your right side heart failure is going to be, I know, it's amazing, left side heart failure. Now, I'm going to let you think about that just for a second. Why is it that left-sided heart failure would be a cause of right-sided heart failure? All right, so let's think about how things are working, and that's why I wanted to go over the AMP. The right side of the body, of the heart, the right side of the heart pumps to pulmonary circulation, right? And then it leaves pulmonary circulation, goes into the left side of the heart. So the left side of the heart starts to fail. It is not pumping adequately. It's not completely emptying the ventricle. It's not pumping out enough of the blood. So eventually that blood starts to back up into the pulmonary system. At the same time, stuff is still going on the way it's supposed to go. So the right ventricle is still pumping blood to the pulmonary system. It doesn't realize that the left side of the heart isn't doing an adequate job over there. So now we have the right side of the heart pumping blood to the pulmonary system, and the left side is allowing blood to back up into the pulmonary system. And this is all kind of stuff going on in the pulmonary system that's not supposed to be going there. Basically, there's a backup, there's confusion, there's congestion. Okay, so with that being said, now we have increased pressures because there's increased fluid there. There's increased circulation. There's too much going on in there. So that's where the pulmonary hypertension goes into. Now, with this backup and this congestion and this confusion, the right ventricle is still working against all of that stuff that's in the pulmonary system. So eventually it's like, look, I don't want to do this no more. This is crazy. So that is how left-sided heart failure can cause the right side to start having some issues, okay? Obviously, a right side MI is going to cause some issues with failure because you have necrosis going on to the myocardium. So it's not going to contract like it's supposed to. The right side doesn't empty completely. You're going to have increased volumes. When we hear increased volumes, what are we thinking? Exactly, increased preload. And so you have increased volumes and increased pressure in the venous system and peripheral edema. Okay. So here's our little lady here. Before you get all confused, no, she's not pregnant. I didn't switch OB on you or anything like this. This is our right-sided heart failure lady. And just so you guys know, we also refer to right-side heart failure as cor pulmonale. So just in case we try to trick you or something on a test and put cor pulmonale, you'll know that that's right-sided heart failure. That was probably caused by the left-side heart failure, right? So here's our little lady. She's fatigued. She has increased peripheral venous pressure. So she has an increased pressure in the venous system peripherally because the blood is backing up where it came from. She does look like she has a big belly because she has increased ascites. That's the system. Everything is backing up into the system. So because things are backing up in the system and she has this extra fluid in her belly, she has an enlarged liver and enlarged spleen. Now this may be, and this goes back to what we were just talking about, it may be secondary to pulmonary issues, right? The right side might be because we were having issues with the pulmonary system. There was congestion in there. There was pulmonary hypertension. And the right side had to work against that. And eventually it was like, don't want to do it, too hard. She's going to have jugular vein distension. So those neck veins are going to be engorged because they are filled with the fluid that backed up. She's going to have anorexia and complaints of GI. Well, of course she's going to have complaints. Her belly is big. All this congestion is going on in her belly. Who wants to eat? You're not feeling really well. She's going to have edema or swelling in her hands and her fingers and dependent edema, okay? I do want you to remember that when you're thinking about peripheral edema, or what we call anasarca, which is edema basically that is generalized, make sure that you are paying attention to weight, because weight is the most reliable indicator of fluid gain and fluid loss. Okay, so we have lots of stuff going on here, guys. We have pretty much talked about what heart failure was, and we said that it is an umbrella. Okay, and under the umbrella, we will talk about if the problem is pumping or filling. Is the actual contractility affected, or is the relaxing affected? Whatever the issue is, it is decreasing the amount of blood that's pumped out of the heart, which is cardiac output. Then we went on to say, wait a minute, is it the left side that's having the issue, whether it's pumping or filling, or is it the right side of the heart that's having the issue? Now, I have to tell you, the body is a dynamic thing. It does some wonderful, amazing things. And one of the things that it tries to do is it tries to compensate for the decrease in cardiac output. So we're going to go on to talk about the compensatory mechanisms for the decrease in cardiac output. So the first compensatory mechanism that responds to a decrease in cardiac output is the sympathetic nervous system. So the sympathetic nervous system actually responds by increasing the heart rate, increasing the blood pressure, and then the release of catecholamines. So the release of catecholamines, and what I mean by that is the norepinephrine and epinephrine circulating all around in the blood, and it causes vasoconstriction. And it also does another thing. It actually shunts blood away from the non-vital organs. So the sympathetic nervous system responds by increasing the heart rate, increasing the blood pressure, and releasing catecholamines, which causes vasoconstriction. Initially, these mechanisms actually do increase cardiac output. Remember, we talked about cardiac output, which was heart rate times stroke volume. And if the heart rate increases, it's going to increase cardiac output. However, they eventually start to damage, because now we have an increase in heart rate. And anytime it's an increase in heart rate, it's an increase in workload of the heart. And anytime it's an increased workload of the heart, it's an increased demand of oxygen. And now we have vasoconstricting. Now we got a sick heart working against that increased systemic vascular resistance. And after a while, it just doesn't do what we really wanted it to do. The second compensatory mechanism that helps out is the renin-angiotensin-aldosterone system. And I have to say, this is one of the systems that I kind of like, so I'm kind of excited to talk about it. So also, in a response to a low cardiac output and a low what we'll call a low oxygenation level, the kidneys get a little finicky and they say, where is my cardiac output? Because the kidneys like to get about 30% of cardiac output. So if cardiac output is decreased, then remember we're shunting to the shunting away from the non-vital organs and shunting to the vital ones, the lungs, heart, and blood, brain. So the kidneys are like, I'm not getting it. So they tend to ask renin to, release some renin there. So we have renin that is released from the kidneys, and they actually act on the angiotensin in the blood, okay? And it converts to angiotensin 1, okay? And angiotensin 1 is converted to angiotensin 2 when it passes through the lungs, because that's where the ACE enzyme is. So the ACE enzyme converts the angiotensin 1 into angiotensin 2. And remember, angiotensin 2 is a potent vasoconstrictor. So also, it's going to increase systemic vascular resistance and increase the blood pressure, because that's what vasoconstricting does. But also, sad face, it increases the workload of the heart. Okay. And it's going to end up decreasing cardiac output for the patient who has heart failure. Okay, so now those little hats that sit on top of the kidneys, they want in on the action. Yeah, the adrenal glands, they want in on the action. So they say, I want in, I want to help out, I want to help out. So they help out by releasing aldosterone. So aldosterone, remember, its job is to retain sodium and water. So sodium and water retention. And on the back end, it does excrete potassium. So that's its job. So now we have vasoconstriction, which is going to give us a higher blood pressure. And we have sodium and water retention, which is going to give us more volume. And this is the body's response to a decrease in cardiac output. There are ways that we can stop this system, and ways that we can kind of stop this system are going to be ACE inhibitors. Remember, I told you the ACE enzyme is produced in the lungs, and it converts angiotensin 1 into angiotensin 2. So if we get an ACE inhibitor, it inhibits that action. So we never have the potent vasoconstrictant. And then we also have your aldactone, which also counteracts the aldosterone. Okay. And the last compensatory mechanism that is in place is going to be myocardial hypertrophy. Myocardial hypertrophy, what ends up going on is that the ventricle gets bigger. Its thought is it will increase the force of the contraction. That's what I'll do. If I get bigger, which is hypertrophy, I can be stronger, and then it will eventually be able to increase cardiac output. That's the whole goal. It's thinking. And it also thinks that it will overcome the increase in afterload. So I want to overcome that increased pressure in afterload, and I want to be stronger. And if I'm bigger, I can be stronger. But eventually what ends up happening is it kind of tires out, and it starts to what we call ventricular remodeling. It dilates, and it just doesn't do its job at all. So now it's not even pumping well. So the compensatory mechanisms to the heart failure or the low cardiac output is the sympathetic nervous system says, give me a blood pressure, give me a faster heart rate, send some catecholamines out, shunt the blood. The renin-angiotensin-aldosterone system has a cascade of events that happen, and those events end up with vasoconstriction, water and sodium retention, which is going to help out with perfusion and cardiac output. And the last one is going to be stronger, bigger muscle, so that it believes that it's going to increase cardiac output. Initially, all of these compensatory mechanisms actually do improve the cardiac output, but then they actually start to work against themselves, and they do not help out at all, because even though my heart is beating faster, even though I have vasoconstrictor, even though I've made myself bigger and stronger, in the end, you have increased the workload of the heart and increased the oxygen demand, and the heart is sick, and that's what the problem is. The pumper is not pumping effectively. So in the end, they still do not help out. So we have certain things that are going on, and what they decided to do, which would be the American College of Cardiology and the American Heart Association, they came together with this classification and staging of heart disease. And not that us nurses stage any of this, but just in case you're tested on it and you want to know, I wanted to put it in here because it is important to know. So the American Heart Association and the College of Cardiology came up with a stage A through D, with D being the worst. And it is basically based on how what are the risk factors and what are the structural defects, kind of like with the signs and symptoms. So a stage A patient is high risk but have no structural disorder. Your stage B patient has structural disorders of the heart but have never had any symptoms. Your C is a past or current symptoms, but they don't have any no underlying structural heart disease. And then your stage 4 patient is at end stage, okay? Now, also, the New York Heart Association came up with a functional classification. I know this is boring. Don't get me wrong. I'm getting ready to move on. But we do have to throw it out there because I would like for them to say something. If something comes on the test and it says something about stage D, I want you to know that's the worst. Stage 4, same thing. So, the New York Heart Association functional thing is how many symptoms are you having, how worse it is. Class 1, heart failure, limited messing with your activities of daily living, whereas stage 4 is you have symptoms at rest. So I thought it was important for us to throw it out there. You really can't talk about heart failure without knowing something, having some kind of understanding about the staging. Now, of course, you know I like to do this. I like to summarize what we're talking about. I know I talk a little fast, so let's get it on. Meat and potatoes. Heart failure is the inability of the pumper to pump, inability to fill. We are either going to have the inability to pump and fill on the left side or the inability to pump and fill on the right side. If these issues are right side heart failure issues, they are all going to end up manifesting themselves into circulation. So you're going to have jugular vein distension. You're going to have ascites in the belly. Your liver is going to be enlarged. Your spleen is going to be enlarged. You're going to have peripheral edema. Everything is going to back up into the system because that's where it came from when it dumped it to the right side. If by some chance the issues are going on the left side and you have left-sided heart failure, because the left side of the heart has received its blood flow from the pulmonary system, it's going to back up into the pulmonary system. So you're going to have your dyspnea, your crackles, your shortness of breath. You're going to have all pulmonary issues. Remember, not all left-sided heart failure is displayed with pulmonary congestion or fluid overload. Remember that systolic dysfunction has a decrease in the ejection fraction, but not diastolic dysfunction, okay? So now, like always, we have to talk about how we're going to diagnose this. What kind of tests are our doctors giving so that we can diagnose this? Remember earlier I said that heart failure was not a disease. It is clinical syndrome. So the first thing we're going to look at is lab work. What is the phlebotomist going to come in and draw? Our number one thing that we enjoy drawing is the BNP, the B-type natriuretic peptide. So with that being said, the BNP is released from ventricular stretch. Yes, and what stretches the ventricles? You got it, volume. Volume is what stretches the ventricles. So, if the BN, and I am not saying BM as in basic metabolic panel, but the BNP is greater than 100, the more severe the heart failure is. Now, the only bad thing about that, like everything else in nursing, nothing is black and white. We cannot exclusively use this to diagnose patients because if a woman is over 60, sometimes she can have a little bit of elevation in her BNP. So that is one that we definitely look at. Less than 100, we won't necessarily call it heart failure. I have actually, in my practice, and I still do practice, seen numbers at thousands. So your BNP is a result from ventricular stretch, and the stretch is caused by volume. And if you think about what we've talked about, it would be a volume that would stretch because the pumper is not pumping or the ventricles are not fully filling with blood. Next thing we're going to look at is going to be the chest x-ray. So we have a patient that came in, they're complaining of whatever symptoms they're having, shortness of breath, belly hurting, whatever the issue is, and we get a BNP on them, and it's about 115. We're not really all that bent out of shape about that. So what we do is we send them down to x-ray. And remember, our main goal when we send our patients down to x-ray is to make sure they're not pregnant and to make sure that we protect them from radiation and stuff like that. So during the chest x-ray, we are able to look at the heart size. See if there's any interstitial edema. And to see if there's any vascular congestion or any effusions. And so that is very important for us to know as well as we are looking at what is going on with the patient. So that is what we're using also to diagnose. Remember, we talked about the hypertrophic heart. So if the chest x-ray shows that we have a big fat heart, we know that we have a diagnostic thing there to look at. The next thing we're going to look at is the echocardiogram. Moving forward, I may call that an echo so that you will know what I am talking about. I am referring to the echocardiogram. I also have that to be in red so that you would know that it would be the most useful for a diagnostic tool. So the echocardiogram is going to look at the chamber size. And when chambers, we're talking about atriums and ventricles. And we're going to look at the chamber function. We're going to look at ventricular wall thickness. We're going to look at the valves and how they are moving. And we're going to be able to assess ejection fraction, okay? And so that's why that is probably going to be our most useful, because we can actually see ventricular wall movement. And so that is very important. We also can look at the ECG, the electrocardiogram, not the echocardiogram, but the electrocardiogram. And that can show us some abnormal rhythms, or that's really what it can show us. It can also show us some left ventricle issues as well. Last thing is coronary artery angiography, and we're going to be looking there for coronary artery disease. So, this is our test where we're basically looking at the dye being shot up, and we're going to look and see how those pulmonary arteries, coronary arteries are being perfused there. So, how that's going on. And then your heart cath to see once again how those arteries, how open they are, how clogged they are, how narrow they are, how dilated they are. And those are the diagnostic tests. We do not just take one test and just run with it. We take a history of physical. We basically look at diagnostic tests, and we look at signs and symptoms before we decide to make a clinical diagnosis. So now, here I go, talking about preload again. So remember I said when I mentioned the word preload, I want you to think about volume. So we need to think about pumper's not pumping effectively, so there's extra volume on board. How can we decrease the preload? Okay, we need to reduce the amount of volume return to the left ventricle doing diastole. Okay, so that's during the relaxing period of the heart. How can we reduce that amount of volume? So IV nitroglycerin. We all know that nitroglycerin is a vasodilator. And so it is going to reduce the amount of pressure that is in the heart. Nursing considerations when we're thinking about nitroglycerin is definitely making sure that we are monitoring our patient's blood pressure, because it's going to open up those vessels. So let's keep that in mind. A decrease in afterload. So remember I told you when you think about afterload, You need to be thinking about vasodilating, vasoconstrictor, big tubes, little tubes, because that's the amount of pressure that the left ventricle has to overcome to push out into systemic circulation. So how are we going to decrease that pressure out there? So we're once again going to have to open up those vessels that are out in there. So one of the ways we're going to do that is with your natural presside, morphine, natural core, and if we reduce afterload, we will improve our cardiac output definitely. Yeah, you guys asked for it, you get a little bit of it. Pharmacological therapies, okay? All of this is going to be related to our patient that we have here. We have a heart failure patient. So I want to talk to you because we need to be able to anticipate why doctors are ordering what they're ordering and knowing when to question an order when it is not appropriate. And we need to have a clear understanding of how this is affecting the heart, whether it's expected response or adverse response. And I want you to have a clear understanding with that. So let's talk about diuretics. Why would we be doing diuretics? What will diuretics do? Absolutely right. Diuresis our patient. Get rid of volume. Yep, get rid of volume. Yes, decrease preload. So when we think about diuretics, we're thinking about the immobilization of edematous fluid, reduce pulmonary venous pressures, and reduce preload. Your thiazide diuretics, your hydrogel, and are usually your first choice for your chronic high heart failure patients. Okay. You're definitely going to think about your loops as well. They are definitely there. Let's think about some nursing considerations because you have your heart failure patient, 65-year-old African-American guy. He comes in and he's complaining of shortness of breath and his feet are swollen and he's coughing a lot and he just doesn't know what's going on. He can't walk out and get the mail and all that. And so the doctor orders him some digoxin, orders him a beta blocker, and also orders him a diuretic. As the nurse, you have to do discharge instructions to send this patient home. And it's certain things that you need to know. So for our patient taking a diuretic, some of the things I would want to talk to this patient about and some of the things I would want to monitor for this patient if they're still hospitalized is blood pressure because volume is volume. The next thing I would like to know is before I give this diuretic is my electrolytes. I love to look at electrolytes. And wow, we talked about electrolytes, okay? So definitely sodium and potassium are my favorite. Definitely my potassium because my loops are potassium, and my thiazides are potassium wasting diuretics. So we want to think about that. We want to do daily weights because weight is the best indicator of fluid gain and fluid loss, and I's and O's. So think about safety stuff like that. Blood pressure, electrolytes, daily weights, and I's and O's. ACE inhibitors, angiotensin converting enzymes inhibitor. So remember earlier I told you that the ACE inhibitor, the ACE enzyme, the angiotensin converting enzyme is produced in the lungs. And the only way to stop the renin-angiotensin aldosterone system is to give ACE inhibitors. So they are the primary drug of choice for blocking that system. They help out with your patient who has heart failure and systolic dysfunction. And your ACE inhibitors are going to be your captopril, benzapril, lisinopril, enalapril. So those are all of your prils. Did I say lisinopril? Okay. So those are the ones. But there are going to be patients that cannot necessarily tolerate ACE inhibitors. And so we'll end up giving them the angiotensin receptor blockers, your ARBs. And those are the ones that we give them. The aldosterone antagonists. So spironolactone, aldactone, it is actually an aldosterone antagonist that blocks the effects of aldosterone on the heart vessels. So it's going to do the opposite of aldosterone. And remember I told you aldosterone is sodium and water retention. And make sure you excrete potassium. Remember, I keep throwing that in. And make sure you excrete it. Okay, so if we give this aldactone, it is actually going to do the opposite of that. They are potassium-sparing diuretics that promote sodium and water excretion by blocking potassium excretion, by blocking the receptors for aldosterone in the distal renal tubules. And yes, I'm going to get a renal video up soon because I know you guys want it. Nitrates. So your nitrates are going to be your meds that are giving you your vasodilation, okay? They are going to relax the smooth muscles of the vessel walls. So nitrates can also be given in conjunction with hydralazine or alprazoline for long-term heart failure management, okay? And once again, we can be giving them to patients that cannot tolerate ACE inhibitors or the ARBs. And then we can't ever forget about our big babies, the beta blockers, BBs. They directly affect the negative effects of the sympathetic nervous system. They affect the effects of the sympathetic nervous system. So, such as the increase in the heart rate. But here's the thing, and this is the sad thing. We all love beta blockers. Beta blockers are our favorites that we like to talk about. But beta blockers also reduce the myocardial contractility. So we have to be very careful with giving these, especially with our heart failure patient. So we may have to start a little bit low and kind of work up when we think about our beta blockers. And our beta blockers are going to be your propranolol, metoprolol, labetalol, all of your logs. And usually the one we're giving is carvedilol, metoprolol and carvedilol, and low pressor and Coret. And you want to make sure that you are checking your patient's blood pressure for all of these medications, because all of this has to do with decreasing the blood pressure and making sure your patient has at least a heart rate of 60. And then the last one is positive inotropes. And positive inotropes mean it increases the contractility of the heart. And when we think about positive inotropes, I want you to think about, there are quite a few of them, I have to be honest with you. Your dopamine, your dobutamine. Here we are actually talking about digoxin lanoxin one. And it increases the force of contractility, but it also decreases the conduction speed in the myocardium. So it works right around the AV node, where the AV node already slows down. And it slows it down a little bit more so that we can have a bigger and stronger contraction, okay? So with this, remember, we're going to take an apical pulse for a full minute. We don't do 30 seconds. We don't multiply by 2. We do a full minute of apical pulse rate. Yes, fifth intercostal space, midclavicular line. I'm sorry, I'm a nursing instructor. We just got to throw it out there. Take your apical pulse for a full minute. It has to be 60 in order to give. For your baby patients, not trying to step on anybody's toes, but it needs to be 100 in order to give your DIG to your little people. The next thing I want you to know is that if your patient is on DIG because maybe they have a chronic issue with heart failure, you're going to once again check your labs, because you're always wanting to do that. Hypokalemia. So a potassium level is going to increase your patient's risk for getting DIG toxicity. So you want to make sure that you know about what your potassium is. Okay. Another thing I want you to keep in mind is to know the therapeutic level of digoxin if your patient is taking digoxin. And the therapeutic level is going to be 0.5 to 2. I know, not much, so you really got to pay attention to that, because we do not want our patient to have DIG toxicity. So that is very important that we know that. So now you want to think about what are some of the signs and symptoms of DIG toxicity. So remember, digoxin works by slowing down the heart rate so that you can get a good strong contraction. It increases contractility. So DIG toxicity is going to be GI disturbances, visual disturbances, bradycardia. GI disturbances, visual disturbances, and bradycardia. Those are the three classic signs and symptoms of DIG toxicity, meaning a DIG level greater than 2. But when I was in nursing school, they didn't say that. They said green and yellow halos for visual disturbances, nausea and vomiting for GI disturbances, and bradycardia. So no matter who tested or how it looks, that's what it is. Those three signs there. It had to come. You knew it was going to come. We're nurses. We have to take care of these patients. So I know it's a lot going on here on your screen here. Lots of stuff as far as our interventions and our nursing management and how we're going to take care of this patient. But we have a heart failure patient. The pumper is not working. The filler's not filling. We have a decrease in cardiac output. So with that being said, we need to make sure that we are assessing for a new S3 and S4. We're assessing for signs and symptoms of hypoxemia. And we need to make sure that we're assessing for signs of fluid overload. And some of those signs of fluid overload are going to be an increase in respiratory rate, a decrease in pulse ox, less than 92, crackles in the lung bases, independent edema, anasarca, daily weight changes. Remember, when we do a daily weight, we should be doing our weight at about the same time every day in the same clothing. So if he sleeps in his boxers, he does his weight in his boxers, and he does it every day. He does it between 5 and 6 o'clock every day. If she sleeps in her cute little raggy gown, she's going to take her weight in her little cute gown, and that's how it's going to be. If she sleeps in the nude, that's what. So we want to educate our patients that you can't take your weight at 6 o'clock in the morning on Monday and then on Tuesday take it at noon. It just doesn't really work that way. So we want to make sure that we are taking same time, same clothing each day. And 2, report to our doctor and understand that a weight gain of 3 pounds, 1.4 kgs over 2 days, or 3 to 5 pounds, 2.3 kg gain over a week should be reported to the healthcare provider. So you have to pay attention to that weight gain. Make sure that we pay attention to the jugular vein distension. We want to make sure that we're looking at our labs. Like always, we want to make sure that we're looking at our electrolytes because they are very important in the management of fluids and cardiac issues. Always looking at vital signs because vital signs let us know things. We're looking at that blood pressure. Remember, all of this, is going to affect your blood pressure, definitely your heart rate. I actually put on here, we're doing strict I's and O's. Yeah, so we don't get to not count some of that stuff. You got to do strict I's and O's when you have your patient on a diuretic. When your patient are having issues with fluid volume. So you want to make sure that you check that. Head of the bed being elevated is really good for dyspnea because you want to make sure your patient can have full lung expansion. I have to be honest with you. I want feet elevated. I'm not sure why I put dangling on there. Guess I was tripping. Supplemental O2, so they may need to have some oxygen, pulse oximeter, frequent vital signs. And then I think that it's also important that you get abdominal girth. So I'm going to add abdominal girth to that. I see nothing wrong with that. The whole thing is we need to make sure that we are trying to increase cardiac output, which is a lot of the stuff that we talked about as far as the pharmacological therapy. But we also want to make sure we promote oxygenation and gas exchange. We like that. Okay. So making sure the head of the valve is elevated so that we can have full lung expansion. Making sure we are assessing the respiratory rate, pulse oximeter, the effort, auscultating lung sounds, looking for if our patient is having any crackles, if we give a diuretic, reassessing, looking for dyspnea, a decrease in lung sounds, maintaining a O2 saturation 92 and above, watching for hypokalemia due to diuretic therapy, and also because, like I said, it places your patient at risk for being ditch toxic. And then we want to encourage our patient to have physical activity and rest periods so that they'll be able to reduce the workload of the heart. So those are just some of the things that we want to make sure that we are assessing as nurses in the hospital and educating our patients on when they are getting ready to leave. The next thing we want to think about is nutrition status. We're going to talk to our patients about dietary changes, and we're going to talk to our patient about weight reduction. We're going to talk to our patient about the DASH diet, which is dietary approaches to stop hypertension. And we are going to put our patient on a sodium restriction. Sometimes it just depends. This is kind of one of those controversial things. Sometimes they are on a fluid restriction and sometimes not. About a 1500 fluid restriction. So it just depends, but you definitely want to talk to them about diet changes. So here is our chronic patient. Okay, so chronic heart failure patient. This patient is fatigued, and fatigue is going to be one of the early signs of congestive heart failure or of heart failure. And then dyspnea. Dyspnea is going to come from interstitial and alveolar edema. And so we definitely want to make sure that we have supplemental oxygen for our patient. They're also going to have episodes. This could be, every other night, every couple of nights, or whatever, especially if at some point they forget to take their medicine of paroxysmal nocturnal dyspnea. Tachycardia, once again, this is an early sign. This is the body trying to compensate. Remember, we talked about the sympathetic nervous system, and that's one of the responses. Edema. This edema is going to be peripherally, liver, ascites, lungs. So that edema could be there. Nocturia. This is basically from all the fluid shifts, and so you're going to have increase of urinating at night. Weight changes. This is going to be from fluid retention, anorexia, and nausea. So you're definitely going to have some weight changes because you are not so hungry and you are not feeling good in your belly and you're holding on to fluid. And then last but definitely not least is going to be chest pain. And why would one have chest pain? Exactly, because we have a decrease in cardiac output. And so that ends up being a decrease in perfusion to coronary arteries. And when we have a decreased perfusion to coronary arteries, we have a decreased perfusion to the myocardium. When we have a decreased perfusion to the myocardium, we have chest pain. So, therapeutic goals for drug therapy. So, we talked about the drug therapy. I talked to you about the ACE inhibitors, the ARBs. I talked to you about the diuretic therapies in this. So the goal is to identify, first thing we want to do is identify the type of heart failure and the causes, because we want to try to work with that. And correction of sodium and water retention and volume overload. We want to have a reduction in the workload of the heart. We want to try to improve myocardial contractility, and we want to control the precipitating and complicating factors. Okay, so all of this is this is your therapeutic goals, and this is why we're giving the meds that we give. So I want you to definitely keep that in mind. Another thing I need you to know is we need to tell our patients when they should call back. When should they call the doctor? When do they know it's getting worse? It's not getting better. So they are having that weight gain. Okay. They're having a decrease in exercise tolerance. So it doesn't necessarily have to be exercise tolerant. They're having a decrease in tolerance of walking to the car or walking up the stairs. They can barely walk from their bedroom to their bathroom without getting dyspneic. They're having lots of symptoms of having a cold. They're having cold symptoms. Excessive waking up at night to urinate, or excessive waking up during the night because they're having dyspnea. Now, how about we went from a decrease in exercise intolerance to the development of dyspnea of rest. So I'm not even doing anything to increase my activity, and I'm having dyspnea. That definitely is a bad sign. So you're sitting there and you're starting to have some chest pain, and you're not doing anything. So you're having dyspnea, angina at rest.
And yesterday, you could put your shoes on, your feet were swollen, but wait a minute, now today you can't put your shoes on at all. Your fingers are swollen, your ankles are swollen, your feet. So those are the things that we definitely need to think about calling our doctor for.
So complications of heart failure. So there's lots of complications, but the most serious complications is going to be pulmonary edema. So, of course, we know with pulmonary edema, your patient is going to have shortness of breath, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and could have some cardiac asthma. So the main thing with this is that if we have pulmonary edema, that we're going to have some issues with gas exchange. So that's one of the things that we have to worry about. And the most common dysrhythmia is going to be atrial fibrillation. And so we definitely have to think about that, because once again, that's going to decrease cardiac output as well. And so I think my next video is going to be over rhythms. So now we're going to talk about nursing diagnosis, because I think in order to be a nurse, you need to know about nursing diagnosis. And I have a question for you guys. What is going to be your priority nursing diagnosis? You're absolutely right. It's going to be a decrease in cardiac output. You're also going to have some activity intolerance. You're going to have issues with volume excess. You're going to have issues with gas exchange. The patient's going to be anxious because they're having issues with breathing. And then you're going to have to do a lot of education because there's going to be some knowledge deficit. So just with all of the things that we've talked about, the patient's going to have a decrease in cardiac output, and that's definitely going to be the priority. Your patient's going to have issues with being able to tolerate activity, not necessarily exercise, but sometimes it's as close as just walking to the bathroom. And that's that's going to be activities of daily living. They're going to have issues with volume excess, and because your patient with left side heart failure could have fluid backing up into the pulmonary system, they're going to have issues with impaired gas exchange. And anytime you are decreased in your gas exchange, you're going to have some anxiety, and they don't know what's going on, so they're going to have some knowledge deficit. And it's our job to educate them on all of that. So now we're going to send this buddy home. And we have to do discharge instruction. So some of the discharge instructions that we need to do is to have them know that they're going to have some modifications and lifestyle changes. And so we want to teach them about the disease process, teach them about their medications, pretty much like I've laid out for you, the functions and any adverse effects and any reasons why they should call. We're always talking about smoking cessation and trying to assess if our patient is ready to stop smoking. We're going to talk to them about sodium restriction. Like I said, we may or may not do a fluid restriction. We're going to talk to them about the importance of daily weights. And we're going to talk to them about the goal. And the goal is always going to be to get them to their maximum functioning level and to prevent readmission to the hospital. So their maximum functional level is their goal, and our goal sometimes is to prevent readmission to the hospital. That's my inside joke. Anyway. So I am hoping that you have a little bit better understanding of heart failure and what goes on with your patient. I hope you understand that heart failure is an umbrella term, and that you usually are going to have issues with contractility, or you're going to have issues with filling, and that it could affect the left side, the contractility and the filling issues, or it can affect the right side. Regardless to what kind or what side or how it affects, it normally has an issue with decreasing the cardiac output. And our goal is to help manage those symptoms and manage those patients. And we're constantly assessing and trying to make sure that we monitor for weights and daily weights, I's and O's, electrolytes, and respiratory status. Thank you, and I'll see you next time.